Good morning, everyone, and thank you for joining us this early morning. We know it's an early start, so we really appreciate that you prefer to be here than in any other room in Geneva this morning. So it's really great pleasure for me to welcome you on behalf of both Save the Children International and Women in Global Health at this side event of the World Health Assembly 78 session. Our event is titled Adapting for Impact, Health, Equality and Rights in an Era of Uncertainty. We want this to be a conversation rather than a very formal session, because we have a lot to share and discuss with our distinguished panelists, whom I will introduce when we get to the panel discussion. It is indeed, you all agree, important that we discuss how do we move forward on health, on rights, on gender at this difficult times that the world is going through. The global uncertainty is immense. Geopolitical conflict, climate emergencies, shrinking civic space, and economic instability, which are all converging to test our resilience and the resilience of our health systems, and challenging the progress we have made toward gender equality and human rights, and also outcomes in global health. Resources are becoming more limited, while the needs are more urgent and complex than ever. However, uncertainty cannot be an excuse for us not to do what we have to do and what we know how to do. Uncertainty is not an excuse for inaction. This morning, we are coming together to ask hard questions and explore new ways of working across sectors, across silos, and across power structures to ensure health and rights for all people, particularly those who are left behind or sometimes, many times, pushed behind. At Women in Global Health, we are acutely aware that the vast majority of the health workforce, nearly 70%, are women, yet they remain underrepresented in decision-making spaces. We believe that equitable health outcomes cannot be achieved without equitable leadership. That's why today's conversation will center voices that have long been excluded from traditional global health power structures. Together with our partners, we aim to create a space that is not only reflective but forward-looking. A space where we can challenge the status quo, spotlight innovation, and forge partnerships that are bold, inclusive, and grounded in justice. I invite each of you, leaders, practitioners, advocates, to bring your full voice to this dialogue. Because adapting for impact is not just about managing change. It is about shaping change. It is about leading change. And we do it together. Once again, thank you for being here with us this morning, and it is now my great pleasure to invite Marionka to set the scene for the panel and explain the structure and how we are going to frame our conversation this morning. Thank you so much.
Thank you very much. And thank you very much on behalf of Save the Children as well for joining us today in this important panel discussion. I would first like to briefly set the scene before handing over to the panel discussion again. And I think what is clear is that we are at a pivotal juncture. The global health and development sector is facing huge challenges. We are seeing a rise of right-wing populism. We are seeing a global health financing emergency and shrinking fiscal aid for countries to invest in health and nutrition. And this is all really reshaping the way the world delivers its commitments to health and rights, and that is especially affecting children, women, and adolescents worldwide. So let me flag 3 key points here to set the scene. Firstly, official development assistance is projected to shrink by 40% by 2027 from 24 levels, On top of that, donor government priorities are shifting towards national security, towards migration management, and increased defense spending. On top of that, in 28 lower and lower middle income countries, debt repayments are exceeding the investments in health and nutrition services that governments can take. On top of that, we see that in 2023, 4.8 million children below 5 died due to preventable causes. And I think that is unacceptable. That is hitting to the majority those in the first days of their life. On top of that, 260,000 women died of pregnancy complications in 2023. The third trend I would like to highlight, and I think you're all acutely aware of that, is the increased rise of a backlash against gender equality, really jeopardizing women's and girls' rights to health, especially adolescent health, including sexual and reproductive health and rights. And what we at Save the Children are seeing is that investments in adolescent health and SHR is the first to be cut under political pressure. And obviously that is unacceptable for us. Numbers are stark and the developments are stark. However, there's also reasons for hope. Regional leadership is increasing, and we've seen that in the past few weeks and months. And countries in Africa and Asia and in Latin America are taking the lead, championing self-reliance, moving towards an increasingly strengthened domestic health financing systems and health systems. The Lusaka agenda is just one case in point, but also when you look at Ghana, Nigeria, South Africa, you've seen efforts to increase domestic resources to invest in health after the funding cuts. But also similarly, when you look at Indonesia and the Asian countries, they are pivoting to South-South cooperation and trying to move away from traditional aid models. On top of that, Brazil and Colombia are advocating for a reform of the global financial architecture and really for building regional coalitions for development. And I think what we can see from these developments is that we are at a pivotal juncture. We need to move from top-down siloed approaches to investing in health and to strengthening health systems. We need to focus on prevention and response while really centering the local voices of those most affected communities, children, women, and adolescents in lower middle income countries. And I'm very much looking forward to the discussion today and to hear from our esteemed panelists and the panel discussion. Now I'm handing over back to Dr. Ravala for panel discussion. Thank you.
Thank you very much, Marionka, for setting the scene and reminding us of the numbers that unfortunately have become our daily digest as we navigate the troubled waters. But just like we did it before, we shall overcome, isn't it? It is now my pleasure to introduce our distinguished panelists. I would like to start from the far right to welcome the Professor Giulio Racortimirina. I'm sorry if I am not pronouncing your name correctly. Professor Giulio is Director of Health, Humanitarian Affairs and Social Development at the African Union Commission, and he's here today representing the African Union Commissioner who could not be with us, but we are very pleased to have you. We also have, after Professor Giulio, our very own Calypso Shalkitu, Director of Health, Financing and Economics at the World Health Organization. I say our very own because Calypso is the department that oversees UHC 2030, and I have the privilege, together with Pam Cipriano, to be the co-chair of the UHC 2030 Steering Committee. Welcome, Pam. Thank you for coming. After Calypso, we have Dr. Ricardo Batista Leite. Dr. Ricardo is founder and president of UNITE, Global Parliamentarians Network for Global Health. He does some other things also, but today we'll stay at UNITE. And you have just heard from Marionka, from the Global Head of Health Policy and Advocacy. It was just spoken to set the scene, I'm pleased that we have a balanced panel. And I would like to start with Professor Julio to ask you, given your leadership at the African Union, how are you seeing the withdrawal of major donors affecting health sovereignty and access to essential services across the continent, particularly for women, children, and marginalized communities? On Saturday evening, we were discussing health financing and the Africa CDC roadmap for overcoming the challenges that we are going through. Please.
Okay. Thank you so much, my dear sister, for giving me this opportunity to speak in front of this audience. So first of all, it is a great pleasure for me to be with you because before becoming director of health, I was a medical doctor at rural health facility, and after that, many years I was becoming director of teaching hospital, and on 2019, 2020, I was the Minister of Health of Madagascar. To say you that on the base of Madagascar's situation, I could give you the overview of many countries in Africa. And of course, actually, as a Director of Health and Humanitarian Affairs at African Commission, it is better to say you that there is a big leadership regarding the health system in general, and also how to take care of children, women. You know that on 2001, African Union Commission decided to have the Declaration of Abuja. And on 2019, they decided to have African leaders meeting led by His Excellency Paul Kagame, which is on health financing in general. These are the points of the leadership. But I can say that the implementation of the ideas inside of these documents, inside of these policies, the implementation was not very, very effective, 100%. And on January 25, we had this, I cannot say challenges regarding the financial context in the world. But I can say that it is an opportunity for African Commission to implement effectively all of these policies. Of course, there is an impact on the ground. This financial context, for example, related to the Karma Plus. Karma Plus is a campaign to reduce maternal mortality. We have also an initiative how to eliminate mother to child transmission of HIV infection. And the decision on January on this financial context have a big impact on that. on our activities. That way, it is a big challenges in front of us, but I'd like to translate it an opportunity. So, one of, I can say you 3 points. For example, for domestic financing, it is better for us to develop and to implement effectively this domestic finance in order to be what to say, pour faire face à ce problème financier. To address. Okay. This is, I think, because we have to develop the implication of private sector on health financing of each country. And this approach was already discussed during 2001 and on 2019. To say that the idea is already ready, but why we didn't do it? That's why I say the declaration after the election in US, we will take it as an opportunity, not a challenge. Because you have already the idea too. The second point also that I want to say is the regional or local manufacturing. For example, the vaccine for the child, for women. It is better that we develop this idea. We have already the idea, but we didn't put it really on the ground.
Thank you.
Okay.
Thank you, Professor Franco-Senolina. We understand that the ideas are there, but we need to move into implementation. That's very important. At a time when we know that there is escalating debt servicing among African countries, I'm told that according to the IMF in 2020, a report of 2024, $81 billion from 2023 to 2025 are being paid for debt servicing, largely surpassing external financial inflows. So there is need for some change to happen and to happen quickly. I'm now going to move to our panelist who is online. I did not introduce her before. We are now going to see her. That's Cheju Moyo, who is the GFF Investors Group youth representative. Good morning. I hope it's morning for you over there.
Good morning, everyone. Just checking if I'm very much audible to the facilitator.
We can hear you loud and clear. Thank you so much for joining us, Chedu. Drawing from your experience in youth-led health initiatives, what are the most urgent barriers young people, particularly adolescent girls, face in accessing equitable health services, and what role can local and global actors play in addressing these gaps? 2 in 1 for you.
That's okay. Thank you so much. And as already shared, my name is Cheju Moyo, and I'm the founder and the executive director for the Lunia Center for Youth in Zimbabwe. I also serve as a youth representative to the Investors Group for the Global Financing Facility. So, as you all know that at the moment, the youth population worldwide is projected at 1.2 billion young people. And of that 1.2 billion, about 90% of young people live in Africa. And in that Africa, in sub-Saharan Africa alone, 70% of the population is under the age of 30. So when you talk about challenges, health challenges, reproductive health challenges and nutrition challenges that are facing young people, we can already see that the burden is mostly in Africa, where we have a lot of young people, and generally in the world, because the population of young people is very high. I can share that complications during pregnancy and childbirth are currently a leading cause of death among adolescent girls and young people in developing countries. You can already see that we have a problem when it comes to maternal health services, in terms of accessing services, in terms of monitoring pregnancies and ensuring that children and mothers survive. And the sad part is that approximately 40% of those pregnancies are unwanted. So the cost is definitely high. We're having these young people, they are dying, trying to give birth, and they are having unwanted pregnancies, meaning that the cost in terms of being able to access and monitor the pregnancies so that they give birth to healthy children is already high. And besides reproductive health issues, the World Health Organization currently estimates that about 35% of the disease burden in adulthood, it stems from adolescence. So I'm still harnessing the fact that the disease burden for young people is very high, and if it goes unchecked, it can escalate into bigger issues. And unfortunately, when we talk about spending, it's estimated that governments and health investments, they spend less than 2.2% on adolescent health, which is a big challenge, because with the money that is invested, it means that less money goes to adolescent health, it goes to, other things, that are not adolescent health and young people. So we have a huge problem of inadequate spending towards health, and the problem in some countries is because of over-reliance on donors. And I think the beginning of the year we saw, the environment, the development environment being fragile, and this has affected, the amount of money that goes towards spending for adolescent girls. Besides fiscal challenges, besides the statistics that I've mentioned, I work with a youth-led organization that works within the community. We still have a lot of cultural, logistical and supply challenges. You can find that there are young people that stay very far to clinics, that stay very far to health centers. And those young people, it means that they cannot access the services, even if they are there, because there are challenges in terms of reaching the clinics. We have some supplies that get to health centers, and maybe they expire before they even use them. Because we also talk about, the increasing heat and climate change that is affecting young people. And talking about these challenges, we have one common goal as stakeholders. The role that stakeholders has to play, we need to come together and engage on policymakers from country level, so that we have a significant amount of domestic resources going towards health. Not just health, but prioritizing young people, prioritizing adolescent girls and young men, because we have a lot of challenges that they are facing. I'll give an example with the Global Financing Facility, what they've done in Malawi. They've managed to support civil society organizations and the government to come together. And they managed to advocate for an increase in domestic resource mobilization. And we managed to see an increase from about 8.5% to about 12.2%. In as much as that is still below the Abuja declaration, but that increase in government spending meant that we now have a lot of resources that we're able to spread evenly across the different sectors of health. So one of the most important things that we have to advocate for is to make sure that we advocate and there is political will. And beyond country level, we know that there's a lot of global health partners and global health initiatives that are supporting countries and civil society organizations. I think the conversation needs to go on. We still need to see the conversation going on, where we engage and we talk about the importance, where we talk about the challenges, and we see where the money should go and how we should channel it. the global financing facility at the moment it chooses country investment cases, which in Zimbabwe has been yes.
Thank you for reminding us of the importance of prioritizing adolescent health and increasing investment for them to access services. Calypso, let me come now to you. Traditional donor funding is declining. Which financing approaches or models, be it domestic financing, innovative financing, blended financing, we are all learning these different terms these days. Which ones do you see as being most viable to strengthen health systems and financing in low and middle income countries?
Thank you. Well, I think we talk a lot about innovative financing, and I think that's good. Some financing interventions are no longer that innovative, but I think it's really important to point out, as we heard from Dr. Julius as well, that domestic public financing has always been and will continue to be the most important source of funding to achieve universal healthcare coverage. No country in the world has managed to achieve UHC with predominantly private household spending or indeed through aid. So the idea of really looking back at the Abuja target and trying to meet it through public, domestic, pooled resources is absolutely critical. But at the same time, as we've heard, there's a lot of dependency because of external aid flows, and this dependency is now playing out in a very problematic way when it comes to populations and geography. So just to give you a couple of stats, I've already heard some from you, Chair, on outflows, which is extremely problematic. But in many sub-Saharan African countries, external aid is still very much the main financier of financing source for healthcare systems. In some of these countries, over 50% of spending comes from external aid. So if we look, for instance, at Western Africa, where there's also instability and climate challenges, foreign aid made up 13% of the GDP of Liberia, about 7% of the GDP, that's the gross domestic product, not health spending, but GDP of Niger and Burkina Faso. And in most of these countries, the US development assistance for health was the main source of external aid and of funding the healthcare system. So US assistance for health made up a third of the current health expenditure in Malawi, for instance, and 25% in Mozambique and Zimbabwe. So the dependency there is it's real. Now, I don't think anyone can argue or should argue that we need to look at replacing one-to-one suspended aid with domestic spending. Domestic spending can be way more efficient. And we know that a lot of the $8, in fact, stay back in the case of the US, a large proportion of that. So there's an opportunity indeed to improve efficiency through domestic funding, but there is also a need to put more money towards health. What we have been seeing post-COVID is that most countries in Africa have actually been deprioritizing health in budgets. So in the context of a shrinking pie, which is the economy shrinking, you also have within that pie, the proportion of the slice size is also shrinking, and that's extremely problematic when governments actually deprioritize health in budgets, reduce the proportion of budget that goes towards health, and that is extremely worrying. So on the revenue side, national governments should really reprioritize budget allocations towards health to protect and sustain coverage of services, and that's through public, pooled, compulsory resources. It cannot be mandatory, and it cannot be fragmented. Now, I think at the same time we talk about debt, but there is a need actually for lending. It says that lending needs to be highly concessional, long-term, very low interest rates. So this is the sort of IDA arm of the World Bank, which got replenished recently, because the size of the gap and the need to boost spending is so great that just talking about mobilizing through taxation, for instance, or it's really problematic. That doesn't mean that there's not a very important agenda of global tax justice that is being discussed at the UN, including minimum tax for corporations, for instance, and wealth taxes under the Brazilian presidency. All of these are very important interventions. But at the same time, I think we need to acknowledge that it's going to be difficult without
significant lending, concessional, high concessional lending coming through. There's other, talking about innovation, just two, three quick points. There's untapped areas. We talk a lot about debt to health. It hasn't really come to scale. This is the situation where basically you swap debt through some arrangement. Part of debt is forgiven, if you like, with the condition that the money goes towards health. Not much has happened there, but we did see recently the World Bank refinance, underwrite basically a debt to education shop in Cote d'Ivoire using World Bank funding, and that's quite important if that were to be scaled. Last year we heard the head of IMF talk about special drawing rights potentially being able to use those, and there's hundreds of billions of these unallocated still to underwrite this kind of transactions, but they need to be scaled up. So far we've seen very, very small scale of 10, 20, 50 million per deal, and that's really small. There is the IMF's Resilience Sustainability Fund, which has programmed tens of billions towards climate, but nothing towards health systems resilience. We're working with the DRC and with Jordan, with the IMF and the World Bank to try and get to one of those deals off the ground, and hopefully, again, we need scale. These things need to happen at scale. Anyway, and I think perhaps one quick point on innovation manufacturing that my colleague was about to mention. I think that's really important when we talk about sustainability. It has to be about a whole ecosystem that includes elements, institutions, African institutions, and notions such as the Africa Continental Free Trade Area, the African Medicines Agency, which will help harmonize the regulatory process, a pooled Pan-African medicines procurement mechanism, which will offer the sort of sustained, predictable, large volumes market, basically. You need markets for inclusive economic growth driven from Africa. So that's I think is incredibly important. And then to close to say that we do have a resolution coming forward, sponsored by the government of Nigeria, and co-sponsored by a number of countries across Africa, Europe, Asia, the Americas, on strengthening health financing globally. And I do hope that it doesn't say anything innovative, it just states things we know work. And these are the things we need to do, and I do hope the Assembly votes it through, and we all work together to implement it. Thank you.
Thank you very much, Calypso, for giving us the ideas, the things we know but we have not been paying attention to, but that matter for increasing investments in health. It is my firm belief that we should continue to advocate for increased investment in health, for putting people at the center, gender, equality, rights, etc. But as health advocates, we need to increase our voices in other spaces. We should not just talk about health. If finances, the reforms that need to happen at the global health financing mechanism don't happen, we will not have money for health. So we should also push in that front. I used to say that most of what we need in health lies in other sectors. So somehow we need to push them so that we get more money. And we are not looking for incremental changes. We need big changes. We need big money. $20 million is not really going to take you anywhere. We need big money. Thank you for reminding us of that. Then now I'm going to ask a parliamentarian, or former parliamentarian, but still very much active and leading a group of parliamentarians, global parliamentarians, a very strong and loud voice of a network for parliamentarians for global health. Ricardo, in your view, how can parliamentarians and policymakers more effectively collaborate across borders and political divides to build a cohesive, equitable, and sustainable global health strategy? I recognize that it is a lot to ask, but we need that cohesive, equitable, sustainable.
Thank you, Magda, and good morning. Good morning to you all.
Good morning.
Thank you. Okay, we need to wake up. We have a heavy week ahead, and it's going to be challenging. But Magda, if you invite me for something at 5 a.m., you know I come. And so we have a Lusophone connection, of course. I come from Portugal, and Magda from Guinea, and working in global health for several years, I always see the Lusophone country somewhat forgotten sometimes, but you have been countering that movement, and if I can help, I will. And I think it's extremely important. And you're helping turn several tides. One is precisely on the Lusophone, and the other is rising the voice of women, which of course is extremely important when we know that 70% of the workforce in health are women, but when we look at leadership roles, it's still at 20-25%, which of course reflects a lot about history. And what we were hearing right at the beginning was the rise of the extreme right and these movements politically which are tremendously challenging. My country just had elections last night, so I do look a bit tired. There are reasons for that. And although my party did win, it's with mixed emotions. One is seeing a victory, which is not a full majority, and seeing the so-called extreme right party reaching to what seems to be the second place, taking away the Socialist Party completely almost off the map in terms of their political dominance over 50 years. And I'm a Social Democrat, which is center-right in Portugal, but there has been some status quo, if you will, of understanding of moderate politics for many decades. That has ended. And I mean, it's something we've seen across Europe. It's not new. And I think it's important to reflect upon this because it does smell like the 1930s in many ways, right? And despite some signs of hope, we cannot ignore these concerning signs. And we have to be very conscious of what is happening. In the 1930s, of course, at the end of the Second World War, the United States played a critical role in a way of saving Europe from tyranny. But there were differences during the rise of the Nazi movement, but also some similarities. And President Roosevelt, who was a strong supporter for freedom at the end, but we cannot forget that at the beginning of the rise of the Nazi movement, President Roosevelt turned away Jewish refugees who were running away from tyranny in Europe. There was one woman who was a moral compass, who turned the tide, Eleanor Roosevelt. And I'm not saying we should put the fate of the world on Melania Trump, but honestly, although as a European woman, I wish she could speak up, because I cannot believe she can agree with everything that is happening. She grew up in this context. She knows what tyranny looks like. But that being said, we need moral leadership. We need moral compasses to step up. Honestly, as we're seeing the political environment move towards this almost alpha male toxicity as dominant, I believe that women are the ones that can turn the tide. And we need that strong women leadership. So when I saw the invitation from this event, I had to say yes. Now, when we're looking at the opportunities that are facing us, and you were asking me, how do we get parliamentarians and policymakers to come together? I served 4 terms in Parliament and founded the Parliamentarians Network for Global Health, Unite. We're in 116 countries. And there's one thing that we've learned, and especially in highly polarized moments like the ones we are living right now, is that trying to promote full-blown change across the board, everywhere, just heightens even more the polarization. And so we've taken what I like to call a Legolytics approach. So it's the application of Lego into politics. I like Lego. And the idea here is very simple. If you have different, when you're building if you buy a Lego set, you know what the end product looks like, right? If you're buying a car, you know that the car, but as you're building it, it doesn't seem like you're building a car, you're just building blocks together. So we have to be intelligent and put in small pieces of legislation that we want to change, those building blocks coming together. And at the end, when we bring it all together, that major transformation happens. But it happens in a way that is almost under the radar. You're not bringing the major challenge to the political discussion, you're discussing one topic at a time. And those smaller changes, those smaller reforms, what we have seen, make it easier for bipartisan or multi-partisan discussions in parliaments. Because it's easier to find coalitions of the willing across party lines if you focus on smaller pieces. Because if you're saying you're going to change dramatically the whole health system or the whole economic system, that's where the polarization, because the media immediately wants to see the position of the extreme right and the extreme left and the center. And that doesn't allow you to have serious conversations. And the truth is, social media is driving politics right now. And so if you're forcing those kind of discussions, you're just going to polarize more and more. So many of us are advocates, of course. Advocacy needs to change, I believe. I think advocacy needs to move towards true political strategizing. And organizations that don't have political strategists that understand real-world politics, they need to implement that into their work streams and into their strategies, because this kind of transformation, I think, is critical. We know parliamentarians bring a tremendous added value because they tend to last longer when we're speaking about health than most ministers of health. And it's important not just to speak to those in the majority, but also to those in the opposition. Political cycles are real. Today, one people are on the top, who's in the opposition will reach that moment of power one day. Keeping cross-party lines open is critical. And making sure that parliamentarians understand the real power. It's the power to not only be the real representatives of the people as they have been elected, they can actually adjust the budget, so the funding issue and the taxations issues depend directly on parliaments, the policy issues, and also keeping governments accountable. That's their main responsibility. It's keeping them accountable in the name of the people who have given them a mandate to lead. And so I think we have in parliamentarians untapped potential. That many times we know that multilateral organizations they respond to member state governments, but at the speed governments are changing, we need some level of stability that I believe parliamentarians can bring, so we can use that untapped potential for change. And as Magda was saying, having a broader view beyond health, but at the same time using political strategy to break it down and build Legos like I do with my 9-year-old son. Thank you.
Thank you, Ricardo, for giving us a sense of what parliamentarians can do. Particularly, it's important to hear that indeed they are an untapped potential that we need to go and bring to our side. Marionka, you set the scene for this event, reminding us that global resources are tight. What are the most urgent reforms that we need in health systems to safeguard and prioritize the rights and needs of children, especially girls, who often face multiple compounded vulnerabilities?
Thank you very much, Dr. Roballo. And I would like to highlight 3 key reforms that Save the Children thinks are crucial. And the first one is really for governments, but also other stakeholders, to invest in integrated, gender-responsive primary healthcare systems, as well as really invest in domestic health financing systems, and generally health systems overall. Because what we can see at Save the Children is that we need to move beyond fragmented, siloed, disease-specific interventions and invest in the full spectrum of care. And that includes maternal and newborn health, that includes mental health, that includes adolescent-friendly services, prevention of gender-based violence, SHR. And we at Save the Children, we are trying to support this. For instance, in Mozambique, where we are delivering an integrated outreach model to offer SHR information and services to adolescent girls aged 15 to 19, living in rural areas, in hard-to-reach areas, really improving access to contraceptives and raising awareness about gender-based violence. But we're also doing this in Ethiopia and in Nepal, where similar interventions have led to marked improvements in health-seeking behavior, especially when their services are offered stigma-free and confidential. yeah, what we can also see is that under fiscal pressure, but also political pressure, SHR services and adolescent-friendly services are the first to cut. And obviously we think that is unacceptable. And that is why we're really calling on governments and all stakeholders to ensure comprehensive SHR is part of a universal health coverage package, as well as for governments to boost up those domestic health financing assistance in order to deliver those services to adolescent girls and women in general. And the second point I'd like to make, and this is really crucial for Save the Children, is to center the voices of women, adolescent girls in decision-making processes. And I think what we've heard already from Dr. Bravallo and others is that girls are often not part of the decision-making process. They don't sit at the table where decisions are being made. And we at Save the Children, we're trying to change this by, for instance, supporting children's parliament through our REACH program in northern Nigeria, where we have strong girls leadership who are advocating policymakers for adolescent SHR. And their activism in northern Nigeria actually led to the passage of the Child Rights Act in 2 regions of northern Nigeria, Katsina and Zamfara, and also secured the first ever adolescent SHR budget in Gombe. And let me quote Aisha Idris Nakano, House Leader of the Children's Parliament. Because girls are informed, they go to school and seek antenatal care and medical help. Now, religious and traditional leaders support girls' education. And I think that quote really illustrates how, when girls are empowered to lead, systems become more responsive and inclusive. And the third point I'd like to add, and I think that has already been mentioned by a few speakers already, is that we need to address the fragmentation of global health architecture. And we need to respond to donor priorities shifting. We need to respond to the funding gaps. We need to respond to weak health financing systems by really pushing global health multilaterals to align their efforts and their strategies for health systems strengthening with each others, to push high-income countries, lower middle-income countries, to work together as much as possible, but also to ensure global strategies really back national priorities. We need to ensure strategies, policies, and funding are country-led and not donor-driven, for instance, by earmarked funding. And this is what we try to support as well in Sierra Leone, where we, for instance, support alignment between donor investments and national SHR priorities, ensuring that rural girls can access essential care, including to SHR. And I think what's clear is that we need broad systemic change. We need local voices to not just be heard, but really lead decision-making processes. And thank you very much for listening.
Thank you so much, Marionka. You mentioned some of the important elements of the Lusaka Agenda 5 shifts, which is really having donors and partners backing national priorities. If I come back to you, Ricardo, you spoke about political strategy and organizations needing to be thinking politically, how they shape their strategies in order to change. You talk about the small pieces of the puzzle, the Lego, but then how do we have partners, parliamentarians helping the system, the ecosystem to shift towards backing national priorities, and then rather than having 80% of external funding bypassing public financing systems, channel them through government so that governments can lead.
I think that it's a very compelling argument for parliamentarians to advocate for their own country leadership. This is not on, right? As I was saying, it's a very compelling argument for parliamentarians to push for their own country leadership, even from a rhetoric perspective. That is something that people prefer. And when we see across the board, especially among low and middle income countries, especially after COVID, the idea of some global north organization coming in and taking over and doing everything for the country is not acceptable anymore. COVID, it was an accelerated way to this major transformation in global health or in aid in general and international development. And the issue is, as the US have stepped away in terms of their tremendous piece of funding, which is very difficult to substitute, the problem is the speed at which this is happening. Because the capacity for this adaptation, for full country leadership, is not there. I mean, there are whole electronic health systems that were based in the US at USAID. As soon as USAID closed, those health systems stopped to be available in Africa. And so the absence of a transition phase is absolutely dramatic. Thousands of lives are at stake. We see that in the HIV movement. I come from infectious diseases as a medical doctor, and we're seeing that the rise of cases. Of course, always young women are the most vulnerable in this context. And so I do believe that there is a need for that country leadership, but there is also a full sense of international responsibility that this needs to go hand in hand with the shift Maria was mentioning about how international development is moving. And countries have responsibilities. And those that say they defend democracy, they defend freedom, they defend international development, have a responsibility to step up at this moment in time, I believe. That being said, you know, what you're asking me, Magda, is how do we convince parliamentarians, how do we convince politicians to then move in this direction? And at Unite, you know, through our work, I came up with an acronym that we use on how to provoke political change. And I think it applies well to health and global health. And it's very easy because we use the first 5 letters we learn at school, A, B, C, D, E, okay? So A is awareness, in the sense that if we're telling a politician that they have to change something they are unaware about, or that their constituents don't know about, it's very difficult to move anything. So that's the first step, which means you have to involve civil society. You have to involve a whole of society movement to create a societal conscious of a situation and create a sense of urgency that it needs to change. Without that A, it's very difficult to make anything happen. B is budget. So making sure that you present a proposal that is realistic from a budgetary perspective. And sometimes, you know, you've been Minister of Health, you know, you're listening to proposals multiple times a day. If someone comes in and says, I have the money, or I know where you can get the money, or we can actually do this with less money, your eyes and ears will open because, okay, finally a proposal that I can work with. And so presenting a key in hand solution to who's in power is critical, and so budget is critical. C is cost of inaction. We don't speak enough about opportunity cost, in the sense that we're always saying what needs to change. We rarely discuss if the politicians decide not to do anything, if the parliamentarian decides not to act, that is a political decision. Deciding not to act is a political decision that has political consequences and leads to certain health outcomes. And so focusing on what will happen if you do nothing is as important on focusing on what will change. D is data, and I work today as CEO of Health AI, the global agency for responsible AI in health. Artificial intelligence and data are going to play a critical role in political transformation, and we have to be much more robust in the way we use these technologies and the way we use data, not just looking at where we are today, but modeling what the scenarios are for the future so we can support the political decision. And to end, E is the most cynical letter of all because it's elections. We're dealing with people who need to get reelected. And so we need to present a proposal that will help them in that process. It's a partnership with the parliamentarians, with politicians. So framing it in a way where incremental gains that they can demonstrate within their political cycle is critical. And so shaping our proposal with that political strategy mindset is so important so that we can get them on board so they can see also what's not in the benefit only of society, but of them also to get that full endorsement and change. It's not an easy task, but that's why Unite is here to try to help, and we are always with the proposal.
Thank you very much. I would add equity to that E.
Yeah.
Calypso, I just have 1 minute for you. I'm sorry. How can financing mechanism, the one you mentioned, be intentional about aligning with gender equality goals, ensuring that investments in health not only expand access, but also address structural barriers women and girls face in using health services?
Well, that's it.
I know it's a mouthful.
I think, well, okay, so if we were to say a couple of things, I think the revenue raising side, right? Talk about domestic resource mobilization, this huge hidden inequities when it comes to how funds are raised. So, for instance, if you take out-of-pocket spending, which is a major driver of spending in many countries around the world, those user fees disproportionately affect women and younger women, and women of all ages. When we talk about access to benefits, right? So that's another pillar of financing. You raise the money, then you spend it. You create these risk pools. So who's entitled? A lot of the time, entitlement is linked to employment, or entitlement is linked to contribution. Women don't necessarily have the power to spend money at the household level. And then a final point is measurement. I think we're really bad at measuring. So when we talk about to measure productivity we know is again, biased, inherently biased as a notion. Women don't participate in the workforce, and when they do, there's a huge bias in terms of salary level. So if you count that, women are less productive because we're measuring things in a certain way. Or when we measure out-of-pocket spending, again, we look at household as a unit, but it's absolutely not a given that women within that unit have decision-making power and access to resources. So how we measure, what we measure, the data, as we just heard, are really important.
Thank you so much, Calypso. We can't measure what we cannot see, so we need to make women to be seen so that we can measure what they are doing and what they are contributing. Professor Rakotonirina, your last question in 1 minute. What coordinated approaches is the African Union advancing to sustain critical health investments, particularly for women and children? When you spoke before, you mentioned the prioritization that is made towards maternal and child mortality. And how can African leadership, equity, and gender equality make sure that gender equality and equity is central in shaping global health governance? I know it's complex, but I would like you to summarize that in 1 minute for me.
Okay, not for you, but for us.
For us.
Okay, so we have the continental policies, many. I can say the EU Digital Health Strategy, EU Roadmap to 2030 and beyond. We have also the Maputo Plan of Action. We have also the African Leadership Meeting. These are policies. But at the meantime also, we have an implementation, continental implementation. For example, the operationalization of CDC. You know that CDC is one of my daughters. But actually, CDC is becoming adjunct. Okay? But CDC is one of our daughters. We are operationalizing actually African Medicine Agency related to the local manufacturing. We are also operationalizing African Humanitarian Agency focused on refugees, IDPs. When you talk about refugees, around 90% are children and women. So by this way, we will reach out effectively this vulnerable population. On April, I sent $1 million to Sahel region to help refugees and IDPs. We are also organizing domestic financial dialogue. Last year, we organized 9. This year, we try to organize more, but during the first quarter, we organized 2.
Thank you. Thank you.
Just one of them, please. And I think that you heard that Malawi said that they will double, multiplier par 2, their
Health spending.
Yeah.
Yes.
To say you there is an activities in Africa, and we need also your support on that. Thank you.
Thank you. You have our full support, and thank you for laying down the policies and governance mechanisms that Africa Union is putting together in order to be influencing more the global health ecosystem. And then last but not least, our young people this morning. Chair Moyo, just for you to close this panel conversation, can you please tell us how you believe in 1 minute we could really meaningfully embed priority for adolescent health into the design and delivery of health services? Just 1 minute. Thank you.
Okay, thank you so much. I'll use my 1 minute effectively. So, most importantly, I think young people or youth-led organizations, they can mobilize effectively by leveraging multi-platform communication. Because we're talking a demographic that has energy, we're talking a demographic that is excited, and we're talking a demographic that has zeal to improve their overall outcomes in the future. I'll give a couple of examples from different countries where I work in Zimbabwe, where the GFF works, because the GFF works in about 36 countries around the world, together with other global health initiatives. In Uganda, we managed to see a youth-led organization integrating youth leaders into district health committees. And they managed to do that, and they eventually led the establishment of youth corners in all health facilities. And they are now providing youth-responsive postpartum family planning services. They not only did that, but they managed to also influence the budget at district level to incorporate those issues into the budget so that they're able to cater for. In Zimbabwe, the Lunar Center for Youth has managed to train over 400 young people to be peer educators, because we use a peer-to-peer led approach. And these are the young people that are able to then engage with other young people to provide educational material for comprehensive sexuality education. And they are then also capacitated and empowered to be advocates, so that in whatever space that they are in, they're able to speak for adolescent health. And we not only do this in silos, we work with other stakeholders. And so this means that the conversation on adolescent health keeps on being had with other young people. And I can also move on to have examples from Cambodia, where we have young professionals. Yes, thank you so much.
Thank you. Thank you so much for those examples of Uganda, Zimbabwe, Cambodia, youth corners, peer educators, etc. I've stolen a few minutes from your time, but thank you. This brings an end to the panel conversation, and I would like to give the floor now to Marionka to set us off. And in doing so, she will tell us the key challenges that we must tackle to ensure underserved groups are not left behind.
And thank you very much, Dr. Robalo. And I could just quickly flag a few of the key barriers that Save the Children is seeing, ensuring adolescent health and rights, and focusing on girls. And I mentioned the fragmentation already, addressing fragmentation in the global health architecture. The second point I'd like to make is gaps in legitimacy of leadership. We need to look at all global health multilaterals and generally multilateral bodies, steering committees and boards, and ensure there is parity between low and middle-income countries and high-income countries to ensure the agenda in global health is set by low and middle-income countries. The third point is the digital and data divide, and Ricardo already mentioned that. In order to develop policies that actually reach those most left behind, we need to know where they are, which means we need data that is disaggregated by age, by ethnicity, by gender, and much more. And the fourth one, really key for us at Save the Children, is a shrinking civic space. We need to counteract that. Like, how do we want to devise policies without the voices of those most affected communities, children and adolescent girls? And only if we do that, policies can be inclusive, sustainable, and effective. And thank you very much. And I would hand back to you, to hand back to the audience for questions. Thank you.
Thank you. Thank you so much. One or two questions. I see two hands on the left and right side in the room, and the third one here.
Thank you so much. So really a very pertinent discussion for this time, and I've worked for the last 15 years in migrant health, so focusing on the health of refugees and migrants and integration. I now work at WHO. And I think one of the things, I guess two just really brief sort of questions or points around particularly how to reach those groups who are urgently being marginalised, not only within health services, health systems response, but also within the current resource constrained environment. And I think here, I very well noted the point around small steps and, you know, making sure that we're working together, but not, you know, the point around advocacy and how we can be most effective. But I wonder whether for those most vulnerable and marginalised women and children, migrants, refugees, those who are displaced, how do we work together best at this moment when there's an urgency in terms of the way the geopolitical climate is, in terms of deportations, in terms of being excluded, being the furthest left behind? Because I think we use that terminology and those words a lot around UHC and inclusion, but how do we actually make sure at this moment that we achieve that? And the second just really brief point is around multilateralism, and I think, you know, of course, that we're talking about structures and systems which we've worked with for decades, well, not myself personally, but as a community. But I just wonder again how, with this sort of deconstruction of a lot of the systems that we have, you know, worked within the UN, and a lot of the multilateral approaches that are now being undercutting the science, how do we now best work together as it's being deconstructed, and how do we have that continued dialogue? And I think, of course, this is probably a big question. Many of you have discussed a few points, but I think, you know, I'm just wondering how we can best not only advocate, but have, you know, impact and action while these systems are also being deconstructed at the same time. Thank you.
Thank you. Maybe we take two questions and then have answers and go back. I apologize, I thought we were about to finish, but you still have some more minutes, which is good. I'm relieved.
Okay, thank you very much. I'm going to be brief. I'm Mariana. I'm a PhD candidate in the graduate school for health policy and system in uncertainty at Bielefeld University in Germany. And I have more like a comment. Researching in uncertainty in antenatal care and listen to the talk, that was very interesting. But I fear that sometimes when you talk about uncertainty, we can erase or cover a bit the terminology on social and determinants, social and commercial determinants of health. Like we mentioned poverty, we mentioned racism, discrimination, and all of these are social and commercial determinants of health. So talk about uncertainty and what is happening in political arena right now, it's directly affecting these determinants. And we need to be careful to, when you talk about systemic change, we should also remember that systemic change comes by tackling the social and commercial determinants of health. That's my comment. Thank you.
Thank you for that comment. I don't know who wants to address the first question.
Yeah, I got to say a few words about her. Thank you. And maybe you put it to you again. Yeah. Thank you. No, thank you very much. Yeah. And no, I just wanted to respond to your questions. How to really ensure health systems include refugees and migrants, especially in these times when there's so much pressure. And I think, and it was flagged beforehand by many of the speakers, but also by Dr. Roballo, that we need to think beyond health. I mean, that's the first thing. So I think we need to change in our policy box our narratives and how we speak about the inclusion of refugees and migrants in health systems. We need to connect it to the fact that the inclusion of migrants and refugees in health systems will also ensure economic development, national and global security for governments worldwide. That's one. The second one is really to put up the pressure on governments worldwide to address their health systems are inclusive, and we could, for instance, use the Global Refugee Forum in 2027 or like high-level meetings in between to ensure governments deliver on their commitments to make health systems inclusive of refugees and migrants. I'll leave it at that. Hello to you.
Okay. Well, thank you for that question. I think it is extremely important. And coming from the HIV movement, I think there's a lot we can learn from that. One of them is that it is extremely important to go local, in the sense that we can have international guidelines and principles and stances coming out of Geneva, but the political strategizing I was mentioning before is building those coalitions on the ground, and that means that when we go local, we adapt to what is important locally. So the arguments we use to shape the narrative that leads to political change will be different from country A to country B, inevitably, if we want to be successful. That is very difficult many times for especially global international organizations like Unite, like others, because it demands tremendous resources to have that localized approach, and that's why having very strong partners, civil society on the ground, but also tapping into local media, tapping into the different movements, even the ones that, you know, are thinking very differently than us. The most extremist movements, understanding how their thinking is happening so that we build our narrative to go and find our way to stream through that challenging environment, I think is extremely important. Of course, that demands resources, I acknowledge that, but that's where I think finding coalitions of the willing between local partners and international ones is going to be critical, and not losing sight of where we want to go, and understanding that this is almost guerrilla warfare, in the sense that we have to go down to the ground. We have to, the idea of passing a resolution in the UN in September at the UN high-level meeting is absolutely useless without this work. And we've seen that. We've passed how many resolutions over these last years that have led to very little. And so we need that kind of on-the-ground change. And maybe just in 30 seconds, because Mariana raised an issue on social and commercial determinants, and listening to Calypso about data, I was just commenting how we also have to align data with incentives. And the truth is, the incentives are still in most health systems today to continue to make money off disease and not off health. And we are spending globally, in accordance to the World Economic Forum, $3 trillion in doing things that do not contribute to better health outcomes. So we're always saying we're lacking money. $3 trillion are being spent on things that do not contribute to improving health of citizens. And that's very easy to understand when you look at how the money is being spent based on a disease-driven healthcare system. And so the fundamental change, I believe, is rethinking even the way we deliver care. And we think of low and middle income countries, the idea that technology can help leapfrog is crucial. And what we need to avoid at all costs, I believe in that sense, is avoiding translating the wrong, broken, disease-driven health models of the richer world and trying to import them into low and middle income countries. That would be a tremendous lost opportunity. This is a time for those that have less infrastructures to be able to use the power of technology to leapfrog into a future where we can rethink and redesign the way we deliver health and care, focusing on quality of life and well-being, and which the determinants have to be a critical part of that discussion and in the incentives model we create.
Thank you so much, and think about doing your Lego when you think about not using models that are no longer working. We need to build new and different models if we want better health for the money that we have. I think we have a question here,
Please.
and then another question. Oh, I'm sorry. Yes, Professor. Yes, sorry.
Okay, I'd like to add some response realities to your question. So there is two systems that we have to organize. First is the inclusion that my sisters said already, the inclusion. And I can give you two examples for Uganda. It is very good example, the inclusion of refugees on their own health system. The second example is Chad. But the problem is, sometimes it creates a disequilibre, imbalance, that the local doesn't receive a good in front of the refugees, and it creates sometimes. So it is better that we. This is the first. The second one is regarding the African Humanitarian Agency, as I said. the African Humanitarian Agency will work also on the health system in order, for example, to give a good healthcare for IDPs inside of a country affected by conflict or disaster. The idea is not to say to, for example, to UNHCR or to say to Croix Rouge, go out, no, but to coordinate. Because sometimes when the actors are coming, they are coming with same activities. So it is better for the African Humanitarian Agency to create who do what, where, and when. Thank you.
Thank you, Professor, and thank you for bringing in IDPs into this, refugees, migrants, and IDPs. They are very invisible. Behind you, Leila.
Thank you very much, and thank you to the presenters. My name is Dr. Balde. I am the Community Rights Agent Specialist at the Global Fund, but I'm also the founding member of Women in Global Health and the lead for Guinea, my home country. As you mentioned, many governments have this priority now into the national budget, but this will really put further behind women and children. What is your vision to help women and children build their agencies in order for them to be able to advocate for themselves, but also to be more inclusive as we are all moving toward universal health coverage? What could be the step that you think would be better for all of us as global leaders to put into place so we can mitigate and move from policy to more operational, at the operational level? Thank you.
Thank you, Dr. Rukiatu. We have another hand at the back.
First of all, thank you to the panelists for a very insightful conversation. I'm Cynthia, and I am policy advisor at the.
Try and speak.
Can you hear me?
Yes.
Yes. I'm Cynthia, I'm policy advisor at the Africa Pandemic Census Collaborative, and I'm very glad to hear the great initiatives going on at the African Union Commission. My question is the African Medicine on the African Medicine Agency. What are the key challenges that this organization is set out to address? Thank you.
Thank you for those two questions. I think we can start with Prof. I hope that mic is working.
Okay, so the African Medicine Agency will coordinate all of the process on the production of medicines. There is 4 steps: the research, intellectual production, the industrial production, that is said local manufacturing, the commercialization or the distribution to the country, and the pharmacovigilance. This is because sometimes you know that many falsified products are circulating in Africa, and many countries doesn't have the mechanism to avoid these falsified medicines. So the African Medicines Agency will work with this country to avoid this problem.
Thank you very much. And then we have the question about women agency and how do we support women to thrive and get to the stage. Maybe we can go to Zimbabwe and ask Teju. What are your perspectives on that? The question from Dr. Rukiatu from Guinea.
Thank you so much. Yes, I think for that one, I would say one of the most important things is to prioritize primary health care. Because if we prioritize primary health care, we are capacitating community at community level that they are, they are strong enough, and we can do this by strengthening community health workers, like village health workers, because these are the people that are there within the community. They are the first line of care. So if we capacitate them before we get to policy level, we know that communities are strong enough, they are resilient enough. We can strengthen them by giving them bicycles for easier movement across the community, even to transport people to health centers, can give them pregnancy test kits so that pregnancies are monitored and tested at an early stage so that we don't have challenges later during the pregnancy. And we can even give them supplies like condoms, family planning supplies. So for me, I feel like primary health care at community level, those village health workers, those people that work within the community, if we capacitate them, we create a sense of agency within the community before we move on to other, policy level or higher level dialogues and conversations. Thank you so much, Oma.
Thank you. Thank you very much. Maybe a final round. I don't know whether anyone from the panel would like to add to the points raised, particularly the first questions. If not, is there any other question? We're good. Thank you. Thank you very much, Rogers, for those important comments and questions that you asked the panelists. I think now it is the right time to say our panel discussion has come to an end, and we are going to proceed with trying to summarize some of the key takeaways from this conversation, which we will take to other rooms and multiply the message, amplify the voices, amplify the messages, and get to the changes that we would like to see. For this, I would like to invite Marionka to give us some takeaways. Thank you.
Thank you very much, Dr. Roballo, and thank you very much to the esteemed panelists for joining us today in this panel discussion on this important issue. And I think today's discussion really underscored the urgency of adopting our approaches, that we can no longer follow a business as usual approach. We really need to question the way we work, and I would like to highlight a few things I've picked up from the discussion. Firstly, we discussed how to center those most affected in decision-making processes and ensure their rights and needs need to guide our decision-making processes. We heard concrete examples how countries can actually mobilize resources, and we also heard how to safeguard adolescent girls' health and rights, to champion gender-responsive financing and boosting domestic resource mobilization. The solutions are there, that's what we also heard, but they require bold and collective leadership. And what I picked up from you, Ricardo, is as well that we need political strategizing, multi-sectoral strategizing across parties, and not just thinking in electoral cycles. We also need to defend multilateralism, and while we need to do that, we need to question the way the system is being set up and really adopt the way global health multilaterals, global health stakeholders, and generally the multilateral system works together with low and middle income countries, and we need to ensure it's not we don't just listen to local voices and those affected most, but really let them lead our decision-making processes, our financing decisions. And I would like to thank you all. Thank you, esteemed speakers. Thank you, Dr. Roballo, for being our moderator today, as well as organizing this crucial event today with Save the Children. And let me hand back to you for some closing sentences. Thank you.
Thank you, Marionka, for summarizing so well the critical discussions we had this morning in this room. I think we will leave this room with, of course, it's like preaching to the converted, but it is important for us to be more aware and make better use of the power that we have, and believe that change is possible and it is within reach. I think the events of January this year brought a lot of negative impacts, but I think it was probably the shakeup we needed in order to realize that we cannot continue the way we are. We all knew that domestic financing was important, critical to increase in order for ownership and leadership at country level to be asserted, and so on and so on. Let's not miss this opportunity for making change. And the first step into making change is the mindset. We can't continue with the same structures of the past. And part of those structures are the ones that prevent women from leading. And those structures should have to be dismantled. Ricardo will forgive me, but I think sometimes we can put